I want to tell you where I come from, and I'll only just do this once. I've got 6 sessions with you, so I thought I'd do it once and get it out of the way. But this is the Prince of Wales Hospital and the Sydney Children's Hospital in one group over here. Across that diagonal over there is 1.2 kilometres, and next door to us is the University of New South Wales with another 1.2 kilometres. So quite a big campus. In a way, we're cheating a bit because this hospital consists of not one but 4 hospitals. We have over here the Prince of Wales Private Hospital on top, the Prince of Wales Hospital below it, and all across all this area over here, and that's my office over there. This is the Royal Hospital for Women, and this is the Sydney Children's Hospital, and that's where I have my office there for the Women's Hospital, and this is where the operating theatres are for all hospitals. So really a very large hospital indeed. These are my disclosures. I can promise you, I think I've acted on behalf for or almost all the companies in the world, and I'm sure all of those guys out there are well represented. However, having said that, I can promise you that all the nonsense you hear this morning from me and over the next few days, none of the lectures or workshops are supported by any grant or any other form of organizational support. And the content is purely my own, which makes it really lousy stuff, but nevertheless. And I want to start off by talking to you about the laundry lesson of near miss. Now you think that on an oil tanker, instructions on how to do your laundry might be one of the smallest hazards you can possibly have. However, after they introduced near miss audit, it became very obvious that there were situations, for example, where a clothes dryer was overloaded and it short-circuited. A dryer working on high heat suddenly overheated. A dryer filter and exhaust ducting clogged with lint and caused a fire on an oil tanker. And you suddenly start to see that fires on oil tankers are not very good things to have. So that basically the decision here was that first of all, the laundry rooms did not have any smoke detectors. Can you imagine a fire in a laundry room that goes undetected for a long period of time? And so basically there was new guidelines put in for maintenance of laundry equipment in the laundry, and also they installed smoke detectors. And since then they've had no fires on these tankers. Now there are plenty of examples I can give you apart from that lesson. This is a photograph you never want to see. This is a JAL DHL freight planes coming so close together that they're almost hitting each other. Now nothing happened from this incident. The two airlines did not crash, and the two airlines never hit each other, but nevertheless, there's a big lesson to be learned here. Somebody's goofed up somewhere in the system. The near-miss concept actually goes back to about 1931 in something that was called the safety pyramid. The safety pyramid was developed by Heinrich, and he was an industrial safety expert at the time. And he estimated that for every 300 near-miss incidents, there are 29 minor injuries and 1 major injury or death. In fact, the theory has never been statistically proven. We don't know if the numbers are right. Other people since then have provided new numbers. But the concept itself is actually quite effective. And it identifies what could have happened after a near miss and correcting that near miss to the point that we have workplace processes in place. And the incident pyramid goes a bit like this. For, say, 600 incidents, these are new numbers, but the same pyramid, 30 incidents of property damage, 10 cases of minor injury, and 1 of serious injury. So really, you must introduce into your hospitals some form of reporting culture, and you should report all near misses, all accidents, all incidents, and in industry, you get this all the time. You know, report that accident and that near miss. Because the accidents and the near misses are probably more important nowadays than reporting the deaths themselves. Now, when it comes to looking globally at all near miss audits, and I'm very glad that Bill Kamen a few minutes ago has laid the groundwork for all of this, of how they report in their hospital when things go wrong, how they recruit additional staff to deal with these problems. You'll see that first of all, you have early warning systems of all sorts. Then you have your near-miss reporting structures. And then in special areas, you might have risk scores for specific diseases or even for a relative from one place to the next. Then, of course, we have all the disease and injury criteria, and I'll go to that a little bit later on. And finally, you have your mortality audits, even systems that have gone along in Australia, for example, for over 60 or 70 years, or in the UK, for example, like the CPOD data. So basically, I think that the message is that a near miss could be the next accident, a near miss in a hospital could be the next death, and so it is very, very important that we report these incidents. Because the sequence of how things go wrong usually goes a bit like this. You have an error event like this, which might be relatively minor. If you detect it and you recover from it, then that's the end of the episode. But if you do nothing about it, it goes on to error event B, and then on to error event C, and you end up with something, little disaster like this, like the little William Tell disaster. In Australia, near miss and safety goes back to this man. This is Bill Runciman. He's the pioneer of it all. He started off the Australian Patient Safety Foundation, and eventually the American Patient Safety Foundation took off from that. It's been around for more than 30 years. And the message is that in anesthesia, safety and quality, I guess, are paramount. And of course, we should now spread the image to the rest of the hospital. We should spread that message all over the place. That in nursing, in allied health, in medicine, we must go to this. And of course, in Australia, we've had these two systems. One is called the Anesthesia Incident Monitoring System, which is a national body called AIMS, and the Anesthesia Critical Event Survey, or ACES, where we report even the most trivial things. Even if a part just breaks, for example, on your anesthesia circuit. You report that, because if they only find one, that's fine. But if they find that there's 500 of them, then that piece of equipment might get banned and pulled out of service. There are some national or inside hospital systems for near-miss reporting. And the ones that are the most important for us are, as I said a few minutes ago, the AIM system, which is the Anesthesia Incident Monitoring System, the ACES system, the Critical Event Surveys, and IMS now, which is rolled out across all our campus. This is the incident monitoring system where everybody, from the porters, the cleaners, the nurses, the doctors, everybody reports incidents as they happen in hospital. And of course, then you have the very big ones, often have been going for many years, like ACES, like the... Now, the first thing I want to talk about a little bit is early warning systems. And I want to explain to you, a bit like Bill Cayman, the all-hands-on-deck system is what we call between the flags. Between the flags is an important paradigm for Australia, because on Australian beaches, you're not allowed to swim anywhere except between the flags. That's the area that's patrolled. If you swim outside that, then the problem is that you're on your own, you have no lifeguard, you have nobody to take care of you once you're out the flags. PACE is the patient in the hospital who requires some sort of acute escalation of monitoring, of taking care of doing something with. This one is interesting because it's a British system which deals specifically with maternity care. And of course, there are many other early warning systems, a bit like Bill Cayman had said a few minutes ago with the all hands on deck. Mortality reporting is important. It's not to say it's not important. The problem with mortality reporting is that it always is after the event, not while it's happening, and you can't do anything about it and escalate it from that point. But there are very many lessons that we have learned over the years from all sorts of things, like SAM, which is the severe acute maternal morbidity, the MMRs, the maternal mortality ratio, which is now a World Health Organization reporting system for all countries, and it's mandatory. We have to report how many maternal deaths we have, and that's how we compare, I guess, health systems. We have CEMD, the confidential inquiries into maternal death in the UK, which has also bred these sort of things like CMACE, CPOD, CMAC, and Why Women Die. Lemon, which is a Netherlands study which is based on the SAM and also on the MMR, but again, it's a cohort-based study for the whole country. We have SCIDUA in Australia, which is all deaths under anesthesia, and that committee has now been going for 40 years. And there's a similar one in surgery, looking at all deaths under surgery within 28 days of the surgical procedure. And we also have, within the hospital, things like SAC, which is Sentinel Event Survey, and the severity scoring systems. So effectively, I think most hospitals, most countries, and most health systems have some sort of system in place. Between the flags is interesting, because between the flags defines every patient in the hospital, basically, and defines parameters which are normal, and beyond which everybody is obliged to report them immediately. So a nurse who comes to a patient in the recovery room who has a blood pressure of more, say, than 160 has to call a doctor to come and look at that patient before discharge. And we have two almost identical systems in place. They're both based on this system. PACE, the patient with an acute condition that requires escalation, and the BTF, between the flags, has been derived from that. What is PACE? It's basically an emergency response system, a bit like the all hands on deck. We introduced that in 2005, and basically we wanted to intervene before the patient deteriorated. It consists basically of a two-tier system. The second-tier system you're all aware of, it's the code blue, basically, which is basically a cardiac arrest situation, or very close to cardiac arrest. But there's also a tier now below that, at which at any time, if you start to deteriorate, the nurses are obliged, the porters, the cleaners, everybody's obliged to call a tier 1 type of near-miss situation. Who is it for? At this stage, it's been rolled out to cover all inpatients in the wards. There are, of course, some exclusions, and the exclusions are places where there already is such monitoring going on already, like emergency departments, intensive care units, the ICU-managed high-dependency units, operating theatres, recovery units, but not the labour and delivery suite. The labour and delivery suite is included in the system. We've rolled it out phase 1 in 2005, and it was complete by January 2009 in all of these hospitals. And then in July 2009, we started off with phase 2 with those hospitals. And in the Children's Hospital, we also decided to go from PACE onto Between the Flags. As I said, Between the Flags is always important in Australia because everybody understands where the flags are. And so everybody relates to the fact that once you have a Between the Flags situation, we know that some patient has exceeded those parameters we've previously set. This doesn't just apply to anesthesia, mind you. It doesn't apply only to nursing. It doesn't apply to hospitals. For example, in crash studies with cars, this is a Navman wireless system. It looks at an incident with the red bits over here being the times when brakes are applied. And you can see that just before this last final incident over here, everything looks fairly normal until the brakes are applied. And then suddenly you have a disaster. The car spins out of control, there's a crash, and this was under controlled conditions. But nevertheless, we can introduce these types of systems not only into medicine, but we can apply them, for example, in our motor cars. Now, I've been involved with this and building the criteria for a PACE system. For example, what do we choose as important criteria in the cardiovascular system? And I thought, or we all thought, that perhaps the heart rate being too fast or too slow is important, a trend in heart rate which is getting worse, a worsening of perfusion, of color, of temperature, of capillary refill, of falls in blood pressure, and also some form of measurement of circulatory collapse of some sort. Of course, when it comes to children, it becomes a lot more difficult because suddenly you now have the flags changing for different weights of child. So a 30-day-old might have a heart rate like that, and a 12-year-old might have a heart rate like that. And again, the blood pressure. Blood pressure, we've estimated the best way to do systolic blood pressure would be 80 plus the age of the child times 2 in millimeters of mercury. That constitutes the flag. And this is how we use these systems to make these decisions. Again, neurological, what would you consider to be important signs of deterioration neurologically? And it's any deterioration in mental state, obviously drowsiness, agitation, combativeness, and so on, but also any changes from the parents in how they perceive the child is doing. It's not enough for us to say the child is getting more drowsy. If mum thinks the child is getting more drowsy, the child is getting more drowsy. So that's an important PACE criterion. Obviously, seizure activity, important. A fall in the Glasgow Coma Scale by more than 2 points, and so on. And there are many others, but anybody can activate this, and in the Children's Hospital, not only the staff, but also a parent concern can activate this between the flags. Again, for respiratory, what do you use? Respiratory rate too fast, too slow, a worsening trend in respiratory rate, an increasing rate of breathing, so if the child develops grunting, or nasal flare, or recession, or gets the head bobbing, or if you have an increase in oxygen requirements by, say, more than 20%, or if you think there's going to be a respiratory obstruction, an airway obstruction, then obviously it doesn't matter for the obstruction to occur. Once you think it's imminent, you call a PACE. You call a PACE if you have worsening stridor. You have a child with stridor whose oxygen requirement is rising, again. Or if the child looks exhausted or looking poor in color in the presence of respiratory distress. Again, as Bill came and explained to you, there's always special forms for these sort of things. And it's very quick, actually, after a while, because all you have to do is tick a few boxes and call the PACE call. And that activates immediately a whole system of people who come and see that child. Of course, we also need modifications to these things in special situations. So we also have modification forms, and we also have modification arrangements, where any senior medical officer can choose to modify the PACE flags for a particular child. So, for example, if you have a child with a pre-existing cardiac condition, say a congenital heart disease child, who has saturations in the 80 to 85, that might be the normal for that particular child. So you have to modify the PACE between the flags criteria to do that. Again, if you have a child who's asthmatic, but is also having salbutamol and has tachycardia from salbutamol, again, you need to move the flags up to accommodate that sort of situation. And that there is what we call the modification form, and that's how we modify them in recovery room, for example, to say that this child can live with a saturation of 80 or 85, do nothing unless it drops below 75, for example. And so it goes on. So a very good system. Of course, the desired outcomes of all these systems is, first of all, early detection and timely intervention. The second is to try and stop people having to go all the way to intensive care when things go wrong, and so to try and reduce the number of admissions to intensive care units. But I think probably the most important thing about this is exactly what Bill Kamen told you about earlier on, that it improves dramatically the interdisciplinary communication between nurses and doctors, between midwives and obstetricians, between obstetricians and anesthesiologists, and so on. And there is improved documentation overall, and there are, in fact, in place medical management plans that are pre-done before we start all of this. And indeed, they do the same in industry. This is known as the 10 steps to RIDDOR in industry. These are the reporting of injuries, diseases, and dangerous occurrences in a factory, for example. And you record the date and the time, and so it goes on. You notify the appropriate health and safety executive person around the place. And RIDDOR is now rolled out to most industries in most countries. There are, of course, some common barriers to near-miss reporting. And I find that these need to be overcome in your hospital before your near-miss reporting becomes accurate. And the problems are these. Some people don't seem to know that they are supposed to report a near-miss. And with the older guys like me, they not only don't report them, but they say, well, we've seen this so many hundreds of times that who cares? So, you know, the old fellas are almost as guilty of this as the young Turks. They don't know how to go about it, especially with the new staff, how to actually do a report without feeling that they're being victimized. They're also, the junior staff are often afraid of being reprimanded or disciplined for actions, in fact, that might have led to the accident or the incident itself. There are also some altruistic type of reasons for not doing this. I don't want to get my boss into trouble. I don't want to get the nurse into trouble. So we better keep quiet. Or they might be so into the team that they feel our team is best. Our team, this is theater 4, and theater 4 never goes wrong. That's my theater. You know, so basically our team doesn't have to report any near misses. We don't have any. And that's a very dangerous situation in many ways. Also with new staff or staff in new hospitals, they always want to make a good impression. They don't have near misses. Not true, of course. They probably have more near misses than everybody else. There's also a work cultural type thing. You know, suck it up. Don't make a big deal out of it. It's going to be all right. Don't worry. And then there's the problem of being ridiculed for having a near-miss accident. You know, it's a trivial thing. It's just a connector that broke on my anesthesia circuit. Why do I want... And they always feel that they might be viewed by co-workers as stupid, or that there's some humor put into this, and they don't see that the hazard could be repeated many times and could eventually kill somebody. And of course, senior staff are again very guilty of this, that when junior staff come and tell them about these little incidents, they belittle them perhaps, or just disregard what they have to say. And of course, there are those, like me, who feel it's just too much trouble to fill out all the forms. And that's a common problem. But remember that these early warning systems are in place. This is, for example, the one that Roshan Fernando is speaking about currently, and it's called the Modified Early Obstetric Warning Score. Thank you, gentlemen. But basically, it's the one that relates specifically to obstetrics. If you do near-miss reporting, you can find trends that are very worrying. For example, this is a study done on staff at a hospital who are driving from work to home after hours, and they are basically having near-miss incidents or even true accidents. And when this happens, you know, they've worked a 24-hour shift. Over here, there are more MVAs, and here we have extended near misses after a 24-hour shift. So it's actually dangerous to drive home after you've been working for 24 hours. In ICU, we've had multiple methods of recording these things for all sorts of diseases: the MOTS score, the Marshall score, the Apache 1, 2, and 3, the SAP score, and all of you know about these. All of them are ways of quantitating how severe diseases are. A risk-based approach to near-miss is very important, because near-miss reporting is, first of all, a zero-cost learning tool. You learn out of things, and it costs you nothing to do. It doesn't require a huge system to do it within your hospital. It's zero cost. So the number of the more near misses you have, the more the reporting tool becomes useful. And the second is that you have an opportunity to involve the behaviors of your staffs. You can actually have a behavior shift. You can share responsibility among your staff. There's more awareness of what other things are doing about you, and also it gives everybody incentive to report these things. The important thing, the message here is that there's no point reporting near misses unless you do something about it. So it doesn't matter, this is just an example of one of these, but basically, you know, you report your near misses and then you try and analyze what it's all about. And then you have to have a response as well put in place all the time. So you need a response manager, you might have a legal implications of this, you might have a control center team, you might have a cardiac arrest team, you might have a medical emergency team, and so on. But if you're in industry, you might have a complaints handling team or a logistics team that does something about all of this. This is one, and I'll finish here. This is the National Health Clinical Communication Strategy. And in 2008, the clinical governance system of our hospital set in a system to try and identify a number of projects. And this is what happens when you do this very, very well. This is the value of near miss, basically, and this had to do with what happens when we transfer patients from one hospital to the next. What are the barriers for a good transfer? And here are the parameters: satisfaction with the information on care, the confidence to ask questions by the patient, the contact given to the patient to try and so on around this sort of thing. And before we started the audit, right, we had that sort of parameter. And you can see that by an educational program and improving the system, you could actually increase your near-miss situation, in this case the audit, and increase the audit to produce increased performance. This is the isobars for all that sort of thing. For example, the staff handover confidence increased. The self-assessed skill improved. The ease of use of the system and the surety of the system. And this is the situation before and going to the situation afterwards. And you can see big improvements over there. Near-miss reporting is often associated with reduced cost. So effectively, as you can see here, as the cost frequency goes down, the near-miss reporting goes up, which is fantastic. So basically, you can prove that near-miss reporting can be useful. And indeed, if you go between 2004, 2005, 2006, 2007, 2008, 2009, you can see that the mortality didn't change. The incapacity rate went down as we reported more of these near-miss situations. A near-miss audit, we go back to the tanker that I started off at the beginning. And this is from the Maritime Safety and Quality Officer. I'm pleased to see that our crew's thought processes are shifting toward assessing what could have happened as opposed to what has happened and reporting it no matter how trivial. And that by improving education, training, and procedures and processes, we have produced a safer work environment. Ladies and gentlemen, I apologize for going over time. I think in the end I'll say that it's better to analyze near misses than deaths in obstetric anesthesia, especially when the mortality has fallen to such a low degree, that the failure to analyze and to act on near misses will not necessarily improve outcome, and that near miss analysis can take many forms, but should be mandatory nowadays in all hospitals, in all factories, in all aircraft, and obviously in all oil tankers. Thank you very much, ladies and gentlemen.